so the question is, now the patient goes on regorafenib and does well with it, and then eventually progresses, as all patients unfortunately do. So what next? I think at every point of the discussion with the patient, even frankly from the first line, the question of palliative care and no therapy should always be part of the discussion. I think it's important to understand the patient preferences, where they stand. Most patients, the majority, overwhelming majority, want to be treated. There are some patients who actually prefer not to be treated at all. They may be older, they may be satisfied with their life and just accept their fate. Most want some form of treatment. But at every line of therapy, I think it's important to have that discussion. And like with first line, second, and third line, now the patient progressed on regorafenib, I will have that discussion with the patient, palliative care versus another option. Another option outside clinical trials would be TAS-102. That is available. And we have data, as I mentioned, that suggests that patients who fail regorafenib and go on TAS-102 still derive benefit from TAS-102. So I would have that discussion, and I think it's very reasonable to consider TAS-102 in this patient, in this particular setting. So I think these are all examples of how much we've gone in terms of improvement over the last decade and a half in treating patients with metastatic colorectal cancer. I mean, our armamentarium has grown so much, not as much as I would hope for our patients, but enough to bring the survival from a little bit less than a year to more than 3 years in the stage 4 setting. And for some patients, let's say those with MSI-high tumors or with specific targets we're able to develop, that survival is actually years and years and years. Those patients with liver metastatic disease only, or lung or oligometastatic disease that are amenable to resection, their survival sometimes is 10 plus years. So overall, I think it's very, very important from day one, when you see that patient, to individualize and strategize of how many lines of therapy am I going to expose those patients to? What kind of strategies are we going to use? Are we going to use surgery, radiation, SIR spheres as part of our global strategy? EGFR, VEGF inhibitors, who is eligible, who's not, left side, right side, immune therapy. And then we have all these clinical trials that are looking at immune therapy in those patients who are microsatellite stable. How can we manipulate the microenvironment, bring those T cells, those lymphocytes, to essentially make those PD-1 inhibitors effective in disease that typically doesn't respond to them? Then we start talking about HER2, an emerging target. And we talk about other targets that also are emerging, EGFR rechallenge, MET, others. And we globally are testing all these questions. So in many patients who may have a multitude of targets, either emergent or present from the get-go, you may think about patients being exposed anywhere between 3 to 4 lines of therapy to 7, 8 lines of therapy, and all done rationally. And then when you start complicating matters with including surgical resection, interventional radiology, radiation, etc., you can see how we can amplify even further the outcome of our patients by providing them with all these various options. And then come clinical trials, innovation in clinical trials, which add even further options to our patients. So it's not unusual anymore to see a patient exposed to an average of 4 to 5 lines of therapy, if not more, for most patients. I mean, all patients, except 5%, will respond very well to first-line therapy. So chances are almost every patient you're going to see in clinic is going to be exposed to 3 to 4 lines of therapy, as long as you strategize well and you've identified targets from day one in the patient's tumor.